Good afternoon again, everyone. Good afternoon. We are going to reconvene. We are hoping to stick to as close to schedule as possible. As you know, we have members across the country who are joining in with us virtually. So we do want to try to stay in line with our agenda and our schedule. Want to take a pause to welcome an additional PACHA member who has joined us. Laura Patero is here with us for the remainder of the day. Welcome, Laura. She was doing some important work in testifying this morning, so glad you're here. Yeah, go ahead. And next up, as you can see on our agenda, I'm pretty excited to introduce the rest of the afternoon's panel conversations. We will start with an update from PEPFAR. Mamadi Ila, Dr. Ila is the Deputy Coordinator for Multi-Sector Relations with the Office of the U.S. Global HIV/AIDS Coordinator with the U.S. Department of State. And Mamadi may not remember, but I was so honored to be a part of the U.S. delegation for the 2021 UN high-level meeting on HIV. And it was fascinating, all of the work and the leadership role that the U.S. plays across the world. So I thank you for your service, and we will turn the floor over to you. Thank you for joining us. Yes.
Thank you. Thank you so much. So let me begin by saying thank you to this community that is PACHA. When you join an effort, it is important that you take time to understand the work that came before you. So on behalf of PEPFAR, Ambassador Nkengasong, and our team at the State Department, we want to thank you for the partnership, for the bidirectional learning that we continue to be committed to together, and how far being data-driven can get us where we want to get to, both here at home and overseas. PEPFAR under Ambassador Nkengasong is building on the work of its previous leaders. As we celebrate 20 years of this remarkable program, let me emphasize what remains central to our success. PEPFAR is mission-driven, focused on accountability, transparency, equity, and impact, and an enduring relationship with the populations it was created to serve. I've got sort of 5 updates. I've got more slides than I intend to share, so I'm going to go through the slides as a backstop to the things I want to say. So the first thing we want to talk about is that this is our 20th year as a program. Incredibly grateful for the resources from the American taxpayer for this work. Ambassador Nkengasong took the story of PEPFAR to Addis Ababa last month to share with 33 heads of state of Africa what it was America had responded to in the creation of a plan by then President Bush in 2003 that had centered around the provision of life-saving medicines that 20 years later had changed the trajectory of HIV/AIDS, particularly on the continent of Africa. The program's outcomes have been spectacular, not only on health outcomes, but also on development outcomes. And for all the 20 years, has enjoyed the support of the now President of the United States, President Biden. So after 20 years, we're taking a minute to take note and to be grateful for the 25 million lives that the program has helped countries save. So in December of last year, Secretary Blinken released our new PEPFAR 5-year strategy, as well as his intention to elevate the political attention to global health security, and global health diplomacy through the ongoing work of PEPFAR by creating a new bureau at the Department of State. The strategy, highlighted here through its purpose statement, focuses on the unfinished work to end HIV/AIDS as a public health threat by 2030 and learn from the lessons of COVID-19, which are that you are best prepared for the unknown by addressing the known and sustainably strengthening the public health systems, the health workforce, the procurement and supply systems, the lab networks, the information systems we need for HIV/AIDS, and the disruptors of that fight, and for countries seeking some type of basic health system in the resource-constrained environments we partner. Our guiding principles, our strategic pillars for a program that has been focused on data, and that data has driven its performance. And now we're at a point where we can stratify our countries around those who are near or have reached 95 UN goals, or near 90, or below 90, so that we can tailor our interventions appropriately. And what is that data telling us? Well, first of all, our strategy is embedded in health equity for the populations most at need. It is telling us that adolescent girls continue to bear the brunt of new infections, that we have not been able to conquer the barriers in serving our most vulnerable, the children, and that our key populations, particularly our men who have sex with men, our transgender communities, are not being reached. Addressing these problems of health equity must be central, and we're working with our teams and helping them with approaches that are readily digestible, doubling down on combination prevention, interventions, and incentivizing innovations born from within the populations we serve. We're also making sure that strengthening of national and regional health institutions are a huge priority to meet our health equity and other goals. We have put goals for regional manufacturing as a tactical incentive, and together with the Global Fund, seek to shape the market, advance regulatory mechanisms, and mobilize non-US financing to accelerate manufacturing of HIV diagnostics. We share a high-level view of the resources that we have had here, which is of interest to folks. And in the last piece of my update is the multi-sectoral table that PEPFAR has set and has been widely satisfying, as much as it has been hard to get all the players around the table to support the country, both through the government that OMB definitely wants us holding to account for the resources that they will need to put on the table eventually, civil society, who is keeping both us and their governments accountable, and we as PEPFAR as partners around the table. We took this tack this year in keeping with the character of our new leader, that we would serve as partners to the countries as we made country operational plans. We had over 1,300 people attend in person over 2 weeks in Johannesburg, and today in Thailand, a number of others concluded their dialogue and planning with PEPFAR. And what transformed us this year, based on this data, that we were not meeting the needs of young people and they remained disproportionately at risk, was the youth who seized the moment in Johannesburg with the speed and ingenuity they offer to influence the approach to ensuring they are not another generation lost to HIV/AIDS, telling us how they wanted to be involved in finding the solutions in our prevention efforts and being an equitable partner at the table we had set. Our final point here is that one of gratitude to both the White House and the Department of State, who have respectfully asked that the PEPFAR program be reauthorized so we can continue to meet the goals listed here. I know you're going to get the slides so you can digest things later, The last thing we want to say is that we take a minute as PEPFAR to honor the work that our colleague Dana Hyde did during her time serving in government that was instrumental in advancing this work. We will never forget her service. Thank you, everyone.
And in incredible fashion, Dr. Mamadi really gave a lot of important updates and very poignant updates about the continued work and needs of young people around the globe and right here domestically at home. And also just thinking through, you know, this bi-directional learning, the panel we have coming up next, really hoping to learn more about much of the successes that have taken place in many of the PEPFAR programs. So we really thank Dr. Ela for all of the leadership, the coordination, and the management of that work over the past 20 years. So I appreciate your service as well. Questions before we move into panel discussions? Any questions or comments for Dr. Ela? Yes.
Thank you so much. We'll say this tomorrow during the global subcommittee report, but we've been really striving at every PACHA meeting to have a place to talk about the global response and PEPFAR's role. So we really appreciate you being here. My question is one to help us, start the conversation that the panel will be focused on, which is addressing stigma, particularly facing gay and bisexual men and trans women. And PEPFAR has unique ways to do that through both everything from guidance to requirements to programming. If you can just share some of the things that that you do from the Office of the Global AIDS Coordinator to try to help countries address very challenging environments. Thanks.
I would say it is our singular challenge as invited guests in other countries to move this agenda. I think COVID was a moment for us in humility to say we ourselves at home haven't gotten it right yet. So this is a partnership. But we do have the opportunity and just the might of who we are as the United States to set that table that I talked about when we get to plan and bring people around the table and actually hear whether or not the interventions we have come up with are actually being successful or not. We have, in one of the slides that went by really quickly, a new incentive this year that is basically saying to our colleagues, the structural barriers that we haven't been able to bring down are impeding the progress we've made. And so even though we've got 20 years of success, we still have to address these issues, and they don't go away. In some ways, it's like whack-a-mole. One minute you feel like you've made progress somewhere, and then it pops up somewhere else. And I know you're all familiar with what we're dealing with in Uganda right now. And it's impossible to just have a blunt instrument because our programs are diverse. The people we serve are diverse. And sometimes attention actually makes things unsafe for the populations that we serve. I know that around this table, there have been lots of things described today of what is going on in the domestic space. And I think we've both appreciated the things that we can bring from overseas and the lessons learned from here. I do want to take a minute because you gave me the floor to thank Harold Phillips, who is a remarkable voice in our global world. And we're just so honored with his role at the White House and the things that he's doing to improve our program.
Dr. Say.
I just want to provide a little context. It's just jaw-dropping, amazing to watch the data as you put it up there, having lived through the 90s when people said, oh, it's impossible. And not only is it possible and going well, I mean, just looking at the 95 countries and then looking at our struggles domestically, it's just stunning what's been done. So bravo for that. One of the questions I have just briefly to capture all this data, there have been set up over the years different informatics systems. And how would you characterize where we are right now in terms of standardized practices that allow pulling all the data together so that you can create your reports and that type of thing? And as a bookmark to us domestically, we need to figure out a way to pool all of our national data from EMRs together, which is all proprietary and makes it difficult, but at least you have the ability to do that. So just a brief comment about where we are with that internationally.
I think one of the things that has helped the program is that from its outset, it started to build things so that 20 years later, I think that some of the permissive environment for the information we've collected would probably be harder today. So I just want to be honest on that point. But I also think it is a core characteristic of this program that it has the ability to report to the level of disaggregation that it has, that has also secured the resources that we have. So I think our partners in country understand that. But maybe what's most relevant today, and just an example that came up this week where there's a lot of information we have regarding our orphans and vulnerable children population that has been captured in our partners' systems, which they report up to us, and are now actively working with ministries of gender and other ministries to make sure they have that information and that's in their own systems as well, because it's really also about how they're able to use the information. Thank you.
Okay. Go ahead, Justin.
Thank you for that really wonderful presentation, Dr. Eula. I'm also always impressed with the way that PEPFAR is able to leverage data in such a real-time way. I guess I'm wondering if there's, as PACHA, we advise the Secretary of HHS about how to make improvements in the domestic HIV program. Is there a lesson that you've seen from your work in PEPFAR that you would offer to your domestic colleagues as something that we should adopt as a best practice that we're not currently doing, that you could think of?
So unfair. I think it's really important to be committed to it, right? And I think that there is a lot to learn about the fact that you need the right information. I think there was a question asked earlier of our community's colleagues. And so sometimes the number says one thing, but you actually don't have the information you need. And to be honest, you can't be afraid of learning the truth. And so I think for PEPFAR, that has been so significant, because at the end of the day, when folks are doing crazy things to prevent access for populations, the data doesn't lie. I mean, we work very hard to get clean data, of course, but the data doesn't lie. And that actually helps you have a conversation agnostic of whether or not you're making this fight with me because we're talking about who gets into the kingdom of God, that kind of stuff. So it's a really important deliverable for all of us to actually be serving people. So keep at it.
Please help me give another round of applause for Dr. Monica. We're going to move right into the continuation of this conversation. Jen Cates and Justin Smith, two of our subcommittee co-chairs, Glenn of the Global Subcommittee, and Justin of Stigma and Disparity Subcommittee. Just a brief word about them. Jen serves currently as the Senior Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation. Widely published, certainly around her work with the impacts of donor investments in global health. Justin Smith, another leader in his own right, Director of the Campaign to End AIDS at Positive Impact Health Solutions in Atlanta. I will turn the floor over to their facilitation and expert hands. Thank you.
All right. Well, thank you, Co-Chair Marlene McNeese. I'm really excited for this conversation. Ever since I got into the HIV movement over 20 years ago, I worked primarily in the domestic space. And I remember when I worked at the University of North Carolina at Chapel Hill, we had a very active research program in Malawi. And I was struck by, even though I worked in the same office as many of my colleagues that were doing work in Malawi, we didn't often share the work that we were doing, even though we were in the same cubicles. And I think that sort of shows up in a lot of places where we have this unnecessary bifurcation between work that's happening on the domestic side and then work that happens domestic in international settings. And this panel is really a way to sort of model how we really need to be working together on solutions for some of our common enemies. And the enemy that we want to talk about combating today is stigma. We know that for many, many years, we've made tremendous advances in our biomedical weaponry to combat the HIV epidemic. What we've done less well, I would argue, is in coming up with solutions to address stigma, which in many ways is kind of almost the harder piece of the work, right? As a colleague of mine in Atlanta, the executive director of Thrive SS often tells us, there's no pill to rebuild will, right? Because stigma actually is what saps people's will. And that's a quote from Mr. Larry Walker. We know that stigma continues to really overshadow and blunt the work that we're trying to do. And we have to be intentional about our work to combat stigma as we are in thinking about the biomedical science of HIV. And that's what we're here to talk about. We know that we've had instances both in our own country recently of really damaging and harmful legislation, over 400 pieces of proposed legislation targeting our trans and non-binary siblings that we know manufacture stigma. We have the law that was recently passed in Uganda that criminalizes identifying as a member of the LGBT community. These things we know will limit our ability to reach our goals of ending the HIV epidemic. And so it's with that spirit, we want to make sure we have a focused conversation about what's really working well. Here in the US, I think we've done a really amazing job of building up the research understanding of stigma and how it manifests. We saw some really powerful examples in the presentations from our NIH colleagues earlier about a special issue of AJPH, which I was proud to contribute to as well, that highlighted some of the advances in understanding stigma from a research perspective. We saw when we visited our colleagues at Us Helping Us yesterday here in Washington, D.C., that are part of developing new measures to combat stigma. And so I think our challenge now is to take that information and figure out how do we turn that into program and policy that can make a difference on the ground. They're all important pieces of the overall strategy, but we want to kind of lift up what's working well and what do we need to do to continue this work. And so I'm really excited for the panel that we've assembled. And we'll get to their introductions. You're going to be knocked out by the brilliance that we have. But I want to turn it over to my colleague, Jen Cates, for her opening remarks. Jen?
Thanks, Justin. I probably should just say what he said. But good afternoon, everyone. Thanks for letting us have this space. I mean, we have 2 hours on the agenda, which, if anyone's been coming to PACHA meetings, is a long time to be able to focus on one really important, complicated issue. So thank you to everyone on PACHA and PACHA leadership to allow this to happen. Also, this is a collaboration between two subcommittees, because we don't on PACHA see global as one thing separate from the work that we're all doing. It really is about the challenges and the issues and so much of the synergies. And it was mentioned earlier that it has been a bidirectional focus that's coming from HHS and the Office of National HIV Policy to really sort of incentivize and encourage agencies and staff across the USG and in the field to share these lessons. And there have been a number of opportunities to do that. And this is yet another one. So focusing on, when we started to create the idea for this panel, we talked about lots of ways we can address it. And what we all decided was we wanted to really keep the focus on LGBTQ stigma in particular, stigma that is directed at or internalized by gay and bisexual men and trans women in particular, not at the exclusion of others, but as the most vulnerable to stigma And we also wanted to understand and include in our view of stigma that it comes in many different forms. It comes in the forms of laws, policies, actions, inactions, violence, exclusions. There's lots of ways that stigma affects people's lives. And we already heard a few people here today have referenced the Uganda law that was passed by the Ugandan parliament, not fully passed into law at this point, as well as what's happened recently in Tennessee, rejecting CDC funding or announcing that would happen, and all of the laws that Justin referenced. So stigma is pervasive. And we know evidence from multiple studies, including one that recently came out that one of our panelists was a co-author on, finding that in Africa, in countries that criminalized homosexuality, HIV prevalence was 5 times higher among men who have sex with men. So we know this has real implications for people's lives in a very dramatic way. We at KFF just a few days ago released a national survey of trans adults in the United States. It's one of the largest representative surveys done of people who self-identify as trans in the U.S. And it was really designed to give voice to a population that doesn't often get voice. But we also looked at lots of different experiences. And just a couple of the statistics that I just wanted to highlight. 1 in 4 say they have been physically attacked because of their gender identity, gender expression, or sexual orientation. And that rises to 3 in 10 among trans people of color, and as well as those who physically present as a gender different than their sex assigned at birth, all or most of the time. And 64% reported being verbally abused or attacked in some way. This is serious health consequences for people in our country and around the world. So we have a lot of work to do. Fortunately, we have a terrific panel today that will delve into these issues from multiple perspectives. And then we'll have a dialogue. They'll each present. We'll have a dialogue with them, and then we'll open it up to questions from PACHA members. So thanks. Do you want to take the time?
So y'all ready? So we have a superstar panel assembled for this afternoon's conversation, and they will present in this order. So first up, we'll have Katie Connor, who's the Director of HIV Services at Crescent Care. Next up, we'll have Dr. Coletso Makafane, who's a Health and Human Rights Fellow at the FXB Center for Health and Human Rights at Harvard University. Then we'll have the first of 2 other fabulous Tar Heels, Dr. William Miller, who is a Senior Key Populations Advisor in the Office of the U.S. Global AIDS Coordinator at the U.S. Department of State. And last, but certainly not least, we have Dr. Tonya Petit, who is Associate Professor of Social Medicine at UNC Chapel Hill. So I believe we have our virtual panelists with us. And with that, I will turn the floor over to Katie. The floor is yours.
Hey, good afternoon, everyone. Can you hear me?
Yes, we can hear you.
Okay. And just going to apologize right now. I'm recovering from COVID. So if you notice a cough drop, that's what's happening. But we're going to power through. So I'm here representing Crescent Care. And we started off as an AIDS service organization in New Orleans, Louisiana in the 80s. And something really important organizationally that we did to try to decrease stigma for our patients is that we changed our name from the No AIDS Task Force to Crescent Care. And we became a federally qualified health center. And we moved locations to help reduce the stigma associated with HIV. A big part of this was, New Orleans is a fairly small city. And now that we offer primary care, dental services, pediatrics, other services co-located with our, infectious disease care, that helps to eliminate stigma for people coming to our building. And our previous location had become known as, the AIDS Tower. And so having a new location now, I think, has been really helpful for people to be able to access care. Our prevention department is pretty extensive, and it's a first point of entry for many from the community that we're trying to reach to enter into care. We make sure that we hire staff to do this outreach work that are from the community that we're trying to reach. So many of our staff in our prevention department are members of the LGBT community and are young people and are able to reach people that way. They have had several grant-funded programs focused on lowering barriers for same gender-loving men and for trans folks to access care. And we all know that the more services, the better to reduce stigma. We started a specific gender clinic around 2016, and it rapidly grew. We have clients that come from neighboring states and several hours away in northern Louisiana because we're a safe haven for gender-affirming care in the South. When demand grew exponentially and our wait list was suddenly months long to get an appointment, we hired 2 more providers, and now our wait list is only 2 weeks for a new patient appointment, which we're really excited about. That's been a big success. We currently serve 1,500 patients just at the gender clinic, and we have 3 providers of trans experience. So we think that that's really important to provide a welcoming clinic for people, especially in the South, where there are not very many services and it's pretty stigmatized. We also expanded this clinical support to include a name change clinic that is helped with our legal department, and people can sign up from the community, come, and they get assistance to fill out all of the paperwork to be able to change gender markers and names on identification licenses, eventually your health insurance, things like that. So it's a really good starting point to really help people navigate something kind of scary, which is the legal system, when they are trying to get the right name that they need for their identification. We also have a syringe service program that's co-located with our clinic, and it has also grown a lot. In 2022, we served 3,700 participants in just 2 afternoons a week, 5 hours each. We offer HIV and Hep C testing, linkage to care, Narcan dispensal and training, urgent medical appointments, and Medicaid enrollment. It was also a big focus during COVID. We set up special testing and vaccine days to prioritize our syringe service participants. And this model of having lots of services co-located really helps to reduce the stigma for people who use drugs and also lowers barriers to getting into care. Our HIV Rapid Start program was very important to fight stigma because delayed access to care can make people feel unimportant and dismissed. With this immediate same-day access to antiretroviral therapy, we're demonstrating that the patient's health is important to us and valued. The protocol also helps eliminate any bias of assessing readiness because everyone is offered ART regardless of housing status, mental health, substance use, etc. And the data from this program has been well documented and accepted into standard of care. An important thing also at these visits is that U equals U is really emphasized and is a helpful tool in the toolkit when the provider is talking with somebody newly diagnosed to help reduce some of that fear. Important next steps that I think nationally we should consider is the HIV criminalization laws that are still on the books. In Louisiana, as a clinic, we have done some work to sort of to advocate against these laws, but there's a lot more that needs to be done to dismantle them. They're incredibly harmful, they're scientifically false, and they are used to criminalize people living with HIV, and we are already living in a very criminalized place in Louisiana where, many of our residents are being locked up, and having HIV criminalization laws on the books, is unnecessary and another thing that we need to get rid of in terms of stigma. And just one other conversation topic I wanted to bring up is that the American Public Health Association passed a resolution last year to try to expand access for women living with HIV into HIV trials. And, I think that this is a huge gap in research and it leads to inequitable care. There are examples of, certain PrEP medications are not approved for cis women because they were not included in the studies. So I'm sure we're going to delve into all of these topics today, and thanks for having me. And and I look forward to chatting.
Thank you so much. Dr. Makafani, the floor is yours.
Thank you. Excuse me. Thank you for this kind invitation. My name is Geleto. I'm an activist, and I'm also a social network epidemiologist. I'm currently at Harvard University. I've worked in global health for about 10 years. I served on the Governing Council for International AIDS Society with Jen, and I have not had the pleasure of meeting Dr. Hila yet, but I have stressed out all your colleagues in country teams at the COP reviews every year to make sure that the COP includes the best of the programming that we know works. So I'm going to speak to you as all of those things, but also a gay man who was living in New York City at a time where there was this emergency, and kind of provide an account of how we responded, and then tie it to the theme of stigma and the theme of connecting global with domestic here in the US. Okay, so the first thing I should say is that I'm representing a lot of people. Here's the spoiler. We did a study to see how group sex particularly happens in New York City as a way of responding to MPOX. And these people are all people who decided to join in the effort of doing that. Not all of them are academics, some of them are. Robert Pitts is a doctor who was one of the first people to treat monkeypox, for example. So it's a grab bag of people, but what we have in common is that we control the data. We made decisions about the study. So the study is called MPX NYC. When it started around May, the idea of it, the context was that we knew there wasn't enough vaccine to cover even just gay and bi men. We knew that testing was so inadequate, like we had about 15 tests a week in New York City. And we knew that there was going to be a rationing decision in the future, and we thought it would be rationed at the person level, not at the dose level, as what happened. Oh, sorry. Okay, sorry about that. Okay, so we knew limited vaccine testing numbers are not good. So if the testing numbers would be used for the rationing decisions, that might create problems. So we wanted to collect some information so that when the time came to ration, at least we have something to add to that decision-making process. And we also had an idea that the way people understand group sex is a little bit outdated, probably. We thought it might be, because the response tends to go to public sex venues, whereas over the past 10, 15 years, there's been drastic changes in the technologies people use to meet up and hook up, and now it's very easy to make a private group. So part of the question was, if we're going to the Cock and the Eagle and all these public sex venues, what are we achieving and what are we missing? Good. And then finally, of course, because it has to do with sex, because it has to do with sexuality, and because it's a disease, it was very clear that it was important to pay attention to how we talk about monkeypox, how we talk to the people taking our survey, how we talk to the press, how we just talk in general in meetings, because of the risk that what we say about monkeypox is entangled with disgust and other kinds of negative orientations towards the type of sex that people who are at risk have and enjoy. So that was definitely a big part of why the visuals look the way they do. The first thing we did, what I was really preoccupied with, is consulting, because I was still am relatively new to New York City, though I've worked in the space for a long time, and had the sense that if we rush in, we launch this big project, we want to get the survey going, and people don't know us, then we might meet resistance, or even worse, we might just not even understand what's going on, where if we had asked, we would understand. So a lot of our effort was behind getting together people who we know, friends of friends, and being very, very meticulous about getting to people so that they can come and consult with us. Am I out of time? Okay. I thought, please just stop me if I run over. Okay, so we used the one on the left, obviously, and so anyway, we consulted on just about every aspect of the study. One of them was how we're going to communicate about it. One of the first things we did was reach out to a marketing agency to say we don't have money, but there is a problem, and we might get money. Well, we said we will have money for sure. We'll have money. You just do your job. I do my job. But we didn't have money, in fact. So we negotiated that, and I'll talk about how we did. But we asked them to come up with ideas for how to respond, and we gave them some criteria. And we decided together in the group which of these 4 designs we'd go with. We went with the first one. It's about emojis. It's about the signs that people use to communicate and negotiate sex online. Okay, I will say another thing, but I'll save it. Another thing that happened that was kind of surprising was that we had this whole effort to consult with people, but what ended up happening is in the first big meeting we had, which was supposed to be a consultation meeting, people said, oh, we actually don't have a space. Like people who work in organizations, individuals, we don't have a space to talk about monkeypox specifically, to talk about what's happening, to talk about emerging data, all of that stuff. So we held that space as, so it moved from a consultation space to a coordination mechanism for people who are interested in working on this problem in New York City. And what ended up happening is that within this, the people who came in and out of the call, about 80 people came through between May and November. People started doing things on their own, things in groups. So these are resources that were created by people who were involved in the community forum, we called it at one point or another. Mpox vaccine locator, we didn't know where to find vaccine. So someone like listed them, made it nice, put it on a website. We had 2 kind of policy brief type things to state and city, Dr. Bassan and Dr. Bassett, and then to the federal government. So you got Mpox as a guidance on what to do if you have Mpox, because that wasn't really around at that time. And 6 ways we can have safer sex is exactly that. It is if people are going to continue having the kind of sex that they want or need or enjoy, or all of those things, then these are things that you might consider if you want to be safer. This kind of communication wasn't happening at that time. And I think we still haven't had that kind of communication. I think there are constraints around what cities and states are willing to publish in terms of health communication. The main thing, of course, was the study itself, and the main innovation of the study, which has been done before but a long time ago, and under different conditions, is to collect spatial data in an anonymous way, so we can't tell where exactly you are. It's up to the level of census tract, but not only on where you live, but where you have group sex. So this map would be presented to the participant. You would tap on the place, you would search for a place, tap on the place where you've had group sex. Then it would ask you what kind of place it is, the frequency of going there, whether you had sexual contact or not. So we ended up having about 1,500 participants. 40% of them said they'd had group sex in the past 4 weeks. And those people gave us about 700 places and described kind of what was happening in those places. And that's the basis for the data that I'm going to show. Just one slide. Okay. So now I had gone to Bernice and said, you guys give us a plan for I think it was like 10, 20, 50, $100,000 and sequence things so that the things that have to happen in the beginning are covered by the first couple of tens of thousands of dollars, and then the actual advertising by purchase we'll cover that later to give ourselves time to fundraise. We did manage to raise over $110,000 from May to November. Well, actually still now, because there is some funding that is being processed by the state of New York City, which still has not been finalized and pushed through yet. So we're using that to do a follow-up round to figure out how people are experiencing monkeypox now and whether some of the findings that we got are durable. But that is a real constraint. This whole area is important because at a time, I'll tell you what happened. The first people to promise us money were AMFA. They promised us $20,000. So I was like, great, we have $20,000. Ran back to my university and said, look, we have $20,000. Now we can work. Let's work. And the response was, well, actually, you can't be speaking to funders directly. There's an office in the university which is in charge of doing that. You need a time machine, basically, because before you even submitted that proposal, it was supposed to have been reviewed by the university. And now the university has to come in and look at, and then negotiate like overhead, all that kind of all that kind of stuff, right? And there wasn't time for that. So we ended up having to work with Prep for All for the funding to come through Prep for All. So the mechanisms for funding this type of stuff need attention because it's going to keep on happening. Okay, so we did all of that stuff. I've been reflecting recently on how to use our experience to plan for the future. And so this is like my very first attempt at a framework for what needs to happen when something like this comes about. We did consultation through the community forum, resourcing I just gave you my story about. It's very important to figure out mechanisms to get money to people quickly. And many of us have that problem. The city of New York, I've been in conversation with, and they had a hard time passing on resources as well to community-based organizations who are going to help with vaccination. So it's not just from the civil society perspective. Surveillance, you can't depend on data that are collected in the clinic for queer and trans people, because queer and trans people don't get to the clinic, and even if they do, there is selection, so you don't kind of have a representative idea. So I think it's almost always necessary to have some other kind of supplemental surveillance activity. Ours was the study that I'm going to show you one slide from. And then coordination, there needs to be a place where people can work together who are not in the same organization, because not any single organization has what it takes to respond immediately, because organizations are contracted to do what they put in their grants. So they can't drop everything and focus. So it's very important to figure out how to mobilize resources, including people's time, outside of the structure of the organizations and agencies they're in. And in reflecting, I think that I didn't read these documents and decide that this is how I was going to approach kind of leading this effort. But this effort comes from the playbook of global health, civil society organizing. Everything from like making sure that it is community-led, not just in name, but in the sense that people are making decisions, and those decisions have power. It's not consultative, it's actually decision-making. It's community-led, it builds the community, it's sex positive, so it doesn't mince words about trying to recommend even for people to do something other than they're doing, except to say there are different options. Some people will stop having sex altogether. Some people will continue having sex. There's some things you can do, So I think a lot of it came from civil society. I'll say one thing that's more recent is the community-led monitoring, which I haven't worked in that space for a long time. But the idea of this process is that community members go and do monitoring and evaluation on clinics, and they own the data. They then negotiate with the clinic to improve whatever it is that they found in the surveys. So that ethic of having that kind of power vested in community comes from there. Okay, so I had planned to give you 5 actionable insights, but I'll give you one for time. So this is an insight that we got from our data that would be useful in responding. By the way, we did run preliminary analyses as we were getting data in, and we did manage to channel City of New York outreach vaccination teams to places where it hadn't occurred to them that people might be having group sex in big numbers there. So we did actually manage to affect kind of how that process played out. But this picture shows it shows how the smallest number of places you'd have to get to reach the first third of people in the darkest pink, in our sample. So if you think it's representative, then the population of people who have group sex who are recruitable on Grindr. So it shows you where you, if I stood in the two pink places, I would reach the first third of people. It's a first third of Black people, Latinx people, white people. So those dark pink places, or almost a third with white people, because there are 3 spots for white people. Those dark pink places are places we can go. We don't have to think about health disparities. We'll find those people there. But the second third of people that we have to find don't all go to the same places. So you can see there's some spots like Latinx people up in Washington Heights and Inwood. Latinx and Black people have Harlem in common, but not white people, etc. So the kind of data we're collecting is directly kind of applicable to the decisions that people have to make in an outbreak situation, or even just in an ongoing epidemic. If you're trying to find people that you think you're not finding for PrEP, for testing, for anything that you might consider. So I think this is it. Right. Thank you. That's it.
We have Dr. Miller on the line.
Yes, can you hear me?
Yes, we can hear you. Okay. Dr. Miller, the floor is yours. Thank you.
Well, first, thank you, Justin and Jen, for inviting me to be on this panel. I'm here from the Office of the Office of the Global AIDS Coordinator, and working with Aaron Eckstein on the Key Populations, Human Rights, and Community Engagement team. And we'll go through a few slides to frame the work that PEPFAR does in 50-odd countries to combat stigma and discrimination. So next slide. So the first document I'll mention is UNAIDS Global AIDS Strategy to End AIDS and End Inequalities for 2021 to 2026. This document was released a couple years ago, and in addition to the 95-95-95 targets, added the 10-10-10 targets. And the first one is to reduce it to the number fewer than 10% of countries having laws that are punitive in relation to key populations and people living with HIV. The second is reducing the number of people that experience stigma and discrimination to less than 10%. And the third is reducing the number of people who experience violence. And so that one of those 10s is specifically related to this topic. And the quote I put in at the top of the slide is from modeling that, as Justin was saying as he introduced the topic, stigma and discrimination, criminalization, and gender equality will prevent the world from achieving other ambitious targets in the strategy and will lead to an additional 2.5 million new infections and 1.7 million AIDS deaths between 2020 and 2030. And so building on that, as Mamadi mentioned, the PEPFAR strategy was released last year to end AIDS as a public health threat by 2030. And in that includes the quote below of, without an intentional focus and dedicated resources for closing equity gaps, including prevention, addressing structural rights and policies, as well as mitigating stigma, discrimination, and violence for the most vulnerable populations, these most vulnerable populations will continue to be disproportionately affected. And so these two documents, along with the 5x3 strategy and that first pillar for health equity, and then finally this focus area on dismantling structural barriers to HIV/AIDS, where PEPFAR is saying that we will also commit to using PEPFAR-supported platforms to stand up against discrimination, violence, and human rights, and call out the inequities or the inequalities in HIV and service access, uptake, and continuity, particularly for children, AGYW, and all key populations. And I know the focus of this panel is on LGBTQ people, but for the PEPFAR space, key populations includes those populations and female sex workers, people who inject drugs, prisoners, and transgender individuals. So this just sort of sets the framework for the interventions that we'll get to in just a second. If you'll go to the next slide. So one more policy document is the COP ROP guidance. This is what sort of guides the PEPFAR country teams and PEPFAR programs to implement the programs in the countries where it's working. And it includes, starting in 2023, a specific topic on 10-10-10 goals and advancing human rights and decriminalization for lesbian, gay, bisexual, transgender, queer, and intersex communities, in line with the memorandum on advancing human rights for those populations around the world that President Biden put out. And then also includes this recommendation to plan and budget for healthcare worker sensitization and training to scale up and reduce stigma and expand KP-friendly services, and then addressing human rights violations and violence among key populations. So these are sort of the recommendations that lead to the programs, and it's a cycle in the sense that interventions and programs to reduce stigma and discrimination have been part of PEPFAR programming since the beginning, and they have fed back into the strategy and the COP guidance in 2023. So it's a circular relationship. Next slide. And just a accompanying document, the technical considerations go with the COP guidance. They have 7 pages on stigma, discrimination, and human rights in the section that's mentioned here, and reference the WHO consolidated guidelines for HIV, viral hepatitis, and STI prevention, diagnosis, and treatment for key populations. And then these are some of the interventions recommended by UNAIDS to reduce stigma and discrimination in HIV responses in different countries around the world. So next slide, we'll get to the brass tacks of what are those interventions that are recommended. So I like what Mamadi said about being honest with each other. And this is where community-led monitoring comes in, because it keeps us all honest about the quality of the programs that are being implemented by PEPFAR. On the far right, there's a cover of a report from South Africa's community-led monitoring program. It's called Richitse. They put out 2 reports specifically on key populations. And at the quote at the bottom describes the reasons for not going to a facility. They may include lack of friendly services, lack of privacy, lack of safety, as well as a fear people would find out that they are someone who uses drugs or a sex worker or a part of the LGBTQIA community. And so these reports are, as Coletso mentioned, data collection that happen at facilities among LGBTQI people, sex workers, and people who inject drugs to understand whether they're getting the services they need and whether the services are friendly, whether they feel welcomed, or whether they are in any way mistreated or discriminated against. And so these 2 guiding questions that I put in the slide are re-emphasizing this year and encouraging country teams, and that means the USAID, CDC, DOD, Peace Corps teams, and implementing partners that are implementing PEPFAR programming to look at what are the barriers to accessing services. How is CLM illuminating stigma discrimination in access to care and the availability of condoms, lube, harm reduction services, STI testing, and other ancillary services? So are those services available? What is CLM telling us about them? And what are the legal and policy barriers or the societal norms that limit access, availability, and acceptability of those services for key populations? And finally, what can PEPFAR do to support countries to address those structural barriers? And then the People Living with HIV Stigma Index is another tool of data collection to help understand what's the level of stigma in society towards people living with HIV and towards key populations, including LGBTQI people. these are examples of what PEPFAR is doing to collect the data and understand the magnitude of stigma and discrimination and the type of stigma and discrimination that exists. Next slide. So another example are the sensitizations and trainings that happen, and the gender and sexual diversity training is a publicly available training. It's online as part of the PEPFAR Virtual Academy. It can and is recommended for U.S. government personnel working in PEPFAR. Can also be taken by implementing partners. It can be an in-person training as well as a virtual one. And then the other two documents with those mosaic tiles are from South Africa, but other countries have these trainings as well. These are a slide deck of 250 slides with videos that are given in person by LGBTQ people in facilities, and these are general population facilities to help people understand the structural barriers, the lived experiences, and the stigma that key populations face in facilities. And I've witnessed one, and they need to repeat over time, but I do believe that they do help change hearts and minds to have the key population members speak to their what they've experienced in facilities. And in addition to these sensitization trainings that are happening in general population facilities, public health facilities, there are also specialized facilities, which is another way that PEPFAR combats stigma and discrimination, is creates one-stop shops or drop-in centers where they are specializing in services for LGBTQ people and offering services like hormone therapy that was mentioned earlier, gender marker changes, STI testing, special services that may not be in the general population facilities. And this is another way that PEPFAR gives key populations, and specifically LGBTQ people, the option of where they would like to go. Is it to a drop-in center that is either staffed by and specifically trained to be key population friendly, or is it in a general population facility that hasn't necessarily had all of the support and training, but is on the way and is is closer to where they live or more convenient. So I think I have one more slide just to give an example of other interventions that exist in the PEPFAR space, and this is something that was developed over the past several years is an assessment of KP competency. And this could be applied to a clinic, to an organization, to a funding agency in a country, to an implementing partner. And it's meant to be a self-assessment so that an organization sits down with a facilitator from the key population community or LGBT community to talk about how they see themselves on a number of criteria. So the first one is from the EPIC project and has 20 questions to self-assess, and then that would be repeated over time to see whether there are improvements in KP competency. And the second one is a toolkit or framework developed by Positive Vibes, and a community-based organization from Namibia that has 25 criteria, and organizations would rate themselves from 1 to 5 based on how competent they are in serving LGBT people. And that would also be repeated over time to see the improvements or declines in KP competency potentially. So I'll stop there and leave you with those examples, and looking forward to the panel discussion and
Can you hear us?
I can hear you now. I could hear nothing until you said that.
Okay. All right. Well, The floor is now yours.
Okay, thank you. Hello, everyone. My name is Tonya Petit. I'm a professor of social medicine at University of North Carolina. I will keep my comments relatively short because I am most interested in engaging in conversation with all of you and thinking together about a way forward. I'm very appreciative of the previous speakers for talking about the kinds of interventions that they've done. So I'd like to talk a little bit about what I have heard people describe their experiences of getting or attempting to get care, what that has been like for them, to illustrate how important this is. I know I, as a researcher and as a PEPFAR alum, I will call myself, have spent a lot of time in data. And sometimes when we spend all of our time thinking about data, we forget about the people who are behind those experiences that are documented in our data. And I've heard in qualitative research that I've done, experiences where people were asked to change their sexual orientation or their gender identity when they went to seek care. People were denied care. People were called names that I'm not going to repeat here, but implying that they were disgusting or dirty because of their sexual orientation and gender identity. People have been stripped naked and put outside as a form of punishment because of their sexual orientation or gender identity. They've been raped and sometimes gang raped because of their sexual orientation and gender identity in the context of a health facility or in seeking care or in their communities. And I don't say that to shock people, but I say it just so that we remember when we're talking about the importance of these interventions, that it's not only about ending the HIV epidemic and increasing access to care, but it's also about humanity and what we all deserve as a human right in terms of being on Earth. I'll just leave it that way. And starting from there, I'd like to talk next a little bit about why data is actually important and what we can do with it, especially those of us who have access to money and power. I was glad to see that William was talking about the PEPFAR gender and sexual diversity training. That training started while I was still at PEPFAR as a key populations advisor. We implemented the first round of trainings in over 30 countries. And I left PEPFAR and entered academia around the time that it became possible to evaluate those interventions. And that evaluation, I think, was critical in demonstrating the efficacy of those interventions. And I think that's the importance of research. So if we're going to be implementing stigma-reducing interventions, they need to not only be community-led and community-derived, but they also need to be evaluated to make sure that they're having the effects that we think that they're having. And what we found when we did these evaluations was that not only did people's attitudes shift a little bit, even after that one-day training, but that the most impactful part of those trainings were the community panels. And I think William spoke to this. In each of the countries, we worked with local community-led organizations, often KP-led organizations, key populations-led organizations, to bring a panel of people together to speak to the folks in leadership. And these are folks in the PEPFAR country offices who are implementing PEPFAR programs about their experience of being a man who had sex with men, a trans person, living in that country, and their attempts to access and engage in care. And those are the most moving things that we found across all of the countries. So I'm glad to see that those are still being implemented. I think next steps in terms of that is knowing that the programs are effective, having the assessments to determine whether or not sites are competent in these areas, is that we then move to accountability. And accountability means that we can't just share information on what is effective, But those of us who have access to power should use that power to make sure that those effective interventions take place. And I think there's a wonderful opportunity for the Ending the HIV Epidemic initiative to use the money and power that's behind that initiative to focus on stigma as one of the really important outcomes, and to hold accountable places that receive federal funding to address stigma and discrimination against key populations, particularly men who have sex with men and trans people. And I want to close with thinking about how important it is to listen to the communities that are being most impacted by stigma and discrimination. The Stigma Index, my cat is joining the conversation. The Stigma Index gives great information. Qualitative interviews give great information. People's lived experience gives great information. And as we look at implementing interventions, holding entities accountable to making change, that we be led by the people who are most impacted by stigma and discrimination. And I think that's really key, and I think summarizes a lot of what the previous people on the panel had to say. So I'd like to stop there so that we have lots of time for engagement around these ideas. And thank you very much for the invitation to be here.
Thank you. All right. So thank you for that really wonderful set of presentations. You've given us a lot to chew on. So I think, what we'll do now is really try to engage the panel as a whole. And we have a couple of questions that we'll pose, but we can really kind of take the conversation where it naturally goes. I think one of the things that we want to take away from this is, across the different settings that we've talked about today, are there kind of overarching kind of key principles? I've heard some of that lifted up, but I really want to be really clear as to what you see as kind of core principles, best practices that should really be at the core of what we do when approaching addressing HIV-related stigma, particularly the HIV stigma that's enacted on gay and bisexual men and transgender women. And, are there components or messages that seem to work better than others? So just be curious for any of you if you have thoughts about that. And again, I think we've gotten nuggets of that through your presentation, but I just want us to be very clear so that, we think about recommendations, we're really clear about what those kind of core principles are. So if anyone wants to jump on that. Okay.
I can kick us off. I think places are different, even within the US, but across the world. But one thing that I think you can be sure about is that queer people and trans people have been thinking about the problems that you'll encounter in your program or in policy you're thinking about, whatever it is you're doing in the space of health. They've been thinking about those problems for a long time. So if you approach them as if they're people who know stuff that you need to know in order to work, then I think you can back out whatever tools you need to back out of those conversations. But I think the first issue that I've kind of noticed is that there is a tendency to treat community voices as if they are not telling you about the social epidemiology of the illness you're talking about. So I think it's to acknowledge that people are saying, hey, I'm telling you about epi now, even though it's qualitative, and build structure around those engagements so that they're not one-off, so that you can't pick and choose who you want to engage, so that if someone is fighting with your office, you are forced to fight with them until the fight is resolved, instead of picking and choosing to talk to. So I think for me, it's like creating structures that really do put community in leadership and that take their thoughts and decisions seriously. And I think on this kind of issue, there are there are pockets to learn all over the place. Like I'm thinking about Kenya and its Key Populations Technical Working Group and the associated groups. Those people are organized. Those people, when there's a problem that comes up that has anything to do with the politics or even the health of queer people, queer and trans people, they are talking to each other. They have a structure and they have a way of approaching the government with one voice. So kind of looking outside and seeing instances like that and how can we replicate, like we've been trying to replicate through the effort that I described, some of those things that make civil society effective at shaping programs and improving them.
Thank you.
May I follow? I hate to follow. So, but.
Go ahead. Yeah.
Okay. The thing I would add to that is those brilliant comments is that what I see happening as I've shifted more of my work to domestic research and interventions is that many stigma interventions in the US are focused at the individual level on building resilience and support systems for people who experience stigma and discrimination, which is absolutely essential. But I think what is also essential is addressing stigma and discrimination at its root and implementing interventions at the level of people who are running those institutions. And that's one of the things I really loved about the gender and sexual diversity training for PEPFAR, that it was at the country team level, because they have the power and the influence and also were often the implementers of programs. And addressing that source is really, really, really critical. And I was glad to see that NIH recently supported an intervention that we are conducting in Ryan White funded clinics to address structural racism and discrimination, including at the intersection of LGBTQ identities at Ryan White funded health facilities in the US. So I think we can learn a lot from that kind of work that's been happening internationally and apply it to the domestic sphere as well.
Great. Wonderful. Anything else that Katie or William, if you want to add anything?
Sorry, I beat you to it, William. So I agree, of course, with everything that's been said. I would say, I'm on this panel coming from sort of a different location because I'm representing sort of a clinic based intervention type model. But something that was really helpful for us was that we organically had some staff who started a trans advisory council at our clinic, and it made it sort of a more formalized way to bring up some of the concerns that they had heard from patients and also that they had seen in the clinic themselves, and were things that they could bring to leadership that needed to be addressed at a clinic, organizational level, to make the clinic itself a more welcoming and respectful place and to increase access. And I think that was really amazing that those staff took it upon themselves to be advocates for themselves and their community and the patients that we serve. And it was really helpful. And it was also something that led to addressing problems in our electronic medical records, to be able to just, it seems like a simple thing, but it really made a huge difference, where we were able to change how you could see somebody's name in the appointment. And so that preferred names were in all caps. It made it a lot easier for everyone throughout the clinic, like front desk and everybody, to not make mistakes in how they address patients, and make sure that they are, being welcoming and addressing people how they want to be addressed. And so I think using that data with our EMR was really helpful. And it led to a big reconciliation project where we realized that the number of people accessing our gender clinic services did not add up to the number that we were reporting for UDS of trans patients that we saw. And so, then we had to do a big reconciliation and go through and fix a lot of the SOGI data within our EMR. And so I think that, having feedback from community and especially an advocacy group like that within the clinic was really helpful to then make structural changes that exist today that make the experience for patients much better.
Thank you. William?
Yeah, so we've heard it, we've said it, but I don't think it is too much to repeat what Tonya was talking about, listening to the community, listening to those that are being served, and if possible, or if there's interest, having services be led by a community, by queer and trans folks. PEPFAR has a handful, or we really don't know how many sort of MSM or trans organizations are out there and funded, but they do exist, funded by PEPFAR, and the hope or movement is to have more of those organizations funded by PEPFAR to offer services. And so that would be sort of the core principle, is like nothing for us without us. Not only nothing about us without us, but nothing for us without us. And including LGBTQ people in the design, in the implementation, in the monitoring, in the any part of the services that are being offered for the population. So that would be my recommendation.
Thank you. You want to add something, Dr.
Yeah, just a little anecdote. A friend of mine early on in the Mpox outbreak had just come back from Europe, lives in New York City. The weekend he came back, started feeling discomfort, little pain, went to an academic medical center to check out. It like lined up with monkeypox. It was like he had traveled at the right time. He had had the kind of sex that was associated with these outbreaks. He was checked for like everything except monkeypox. He went through 4 providers. It took him a week for a doctor to say, this looks like monkeypox. And that doctor examined him on FaceTime, because there was just no way of, all the people that he'd been through had just not helped him. He started having pain. So this happened on the weekend. He started having pain Monday, Tuesday. By Wednesday, the pain, which by the way, people who've had monkeypox rectally describe it as the worst pain of their lives, like horrific bleeding, horrific pain. So he had that kind of pain. He went to the doctor. Doctor didn't know what to do, and they didn't even treat him for the pain. So he had to figure out his own prescription meds for pain, right, among his network. All that's to say, like, stigma is operating there, for 4 people to like pass you by and for not one of them to say, okay, now you're my problem, I'm your doctor, we're going to solve this problem together, is absolutely shocking. We had reports of doctors not wanting to even examine patients, but sending them on to Callan Lord, which is a community-led health center, very qualified community health center. And so there is stigma at that level. I think that there is a tendency to think, you look at Africa and there's criminalization laws on the books and you think, okay, that's where the problem is. Here in the US, we have marriage and we have protections, and so like things are okay. But even at the level of those clinical encounters, I think there's such an important problem to solve, and it doesn't feel like people acknowledge that. I was in touch with New York State right at the beginning when the numbers were small, and was saying, oh my gosh, what's going to happen? Like we've seen 1 or 2 cases in New York City, and there isn't 1 or 2 cases of anything in New York City. It's a big, dense city. So, and so what are we going to do about testing? And they were like, oh no, we've told our providers about what's happening. We've told them monkeypox presents this way now. We've told them that, this is a pathway to getting medications. And, and to me, it was really, really unbelievable because in the context where I work, telling providers about that stuff is like a week-long training with a panel of people who will tell them, this is how I feel when doctors treat my rectum as if it is like the most evil place in the world, you know? So the acknowledgement that we are still facing those problems in the clinical encounter, I think is an important one that still needs to happen. And it is the basis of a bidirectional communication with people who have been doing this work in other regions of the world. You haven't solved all the problems here. I say you, I'm married to an American. I think I'm on my way to becoming an American. I'm from South Africa. But yeah, the issues that happen at that level seem to happen here as well. And I think it's important to like think about that as an opportunity to join hands and to think together with people who are in other regions.
Thank you.
We already have a lot of cards up. I have one thing I wanted to just ask, and then we can go to cards to put them up. Thank you so much. This has been just exactly what we were hoping for, and getting out sort of the key principles or ideas is really. I've been writing them all down. One that I heard that is maybe not a principle, or maybe the principle is that context does matter, because one approach that I heard Katie talk about was, and we know this from evidence that this works, is you integrate services and you provide a range of services to a range of populations so that people coming do not feel that they're going to a particular location that's stigmatized. And the flip side, and William talked about this, is when you really need, for safety or other reasons, to have a safe space that is really just for that community. So I think both are under the same principle of what's the safety that the population needs in this context. That's important to remember. I remember when PEPFAR started those trainings, because Tonya and I talked a lot at that time, and it would be maybe not here, but just understanding how that happened, what it needed. Was there additional funding that needed to be allocated for it, which I assume there was, and the various steps, because how applicable that could be to U.S. domestic programs. Since our purview is HHS, is PACHA, we're always thinking about what are the HHS levers, policy or otherwise, that can be utilized to promote stigma reduction activities at the clinic level or at the grantee level, et cetera. So to the extent that you have thoughts on those kind of interventions, that would be really helpful to hear. Thanks. And Tonya, you already started a little bit with your Ryan White example.
Okay, I was wondering if that was a question for me or wanting me to comment. I will say, having worked at the Centers for Disease Control and Prevention and having worked at OGAC, that within those organizations, there's still a lot of advocacy to do. And for folks who are outside of those agencies, the ability to represent the advocacy that's coming in and be responsive to that cannot be overestimated. So we need advocates to push in order to make change from within as well. And I hope Mama D is not going to leave the room as I say that.
What she's saying is she was a big part of making it happen. So those lived experiences and people actually being a part of the leadership of organizations like ours matters enormously.
Okay, thank you. So yes, I mean, as a queer person for whom this matters a great deal, for me, my family, friends, and loved ones, part of what I wanted to accomplish during my time at PEPFAR was to, one, increase visibility of trans people as part of key populations work. And the second was to try to make some visible commitment to the community, and advocates were a really important part of me being able to say, the advocates are out there and they're losing it if we don't do something, it takes that too, to be able to make that change inside. And it did take funding. There was the Key Populations Fund, which I think has now evolved into even greater resources. And we felt like it was really important before we ask country teams to implement key populations programs that they do it right. There is definitely the possibility to perpetuate stigma in attempts to address key population healthcare, and making sure that they heard from their own communities about their experiences and they had some basic information around stigma reducing ways to go about their work was critical.
Thanks. Anybody else want to add in? Okay, I think we can go to the room, but please, at any point, this should be a dialogue. So Marlene had her card up first. Let's go around this way because I wasn't keeping track.
Sure, I'll be really brief. I just wanted to say I was so looking forward to this panel for this afternoon, and you did not disappoint at all. I really appreciate really a lot of the themes around each of your talks. And really for you, Dr. Makafani, when you mentioned community power, and that word power was really invigorating to me. Not just community advice, but really community-driven leadership and change. And I think even you, Dr. Miller, mentioned it yet again when you described the activities around community-led monitoring and really having the community lead the force for accountability and evaluation. I really appreciated all of that. So I just really wanted to give kudos quickly about my reaction to the panel conversation. But I had a very specific quick question for Katie. I was intrigued by your name change department. Apparently it sits in your legal area. How is that funded, or how did you create ways to support that activity for your patients?
Thanks. So it's sort of a pop-up clinic that we do, and because we do have limited resources for it, but we have people sign up ahead of time, and I think we can do at most 20 people in an afternoon because, of course, the paperwork and everything is very time consuming to try to get anything done bureaucratically like that. The legal department that we have housed with us is called AIDS Law. So they primarily work with discrimination cases for people living with HIV, whether it's for housing or for jobs and things like that. So their time is just donated to this clinic. And then in terms of the fees that people have to pay, one, local trans advocates were able to get the fee lowered in New Orleans at the court level. So that was just a huge political win that they did. Because I think it used to be, I'm going to get these exact numbers wrong, but I feel like it used to be, $500 and they got it down to $100, something like that. It was a big change. And then the people who sign up for this name change clinic, I believe we use some funding from the clinic itself to support that. And I'm not sure if we ended up getting support from Ryan White to help with that as well. But I know that we have lots of grants in our prevention department to increase access for trans folks to care. And so maybe that we were able to shift some over like that. But so it's not we're not doing it all the time, but we do set it up, and then it involves a lot of staff people, and people sign up ahead of time. So it's not constantly available, but it is something that we're trying to make a regular thing that we do, I think, about like once a month. But it's been really great. And I think it's also a nice way to sort of introduce the clinic to people, even if they are not patients, right? That this is something like we care about the community. And this is something that we are trying to help with, whether you access care here or not.
Thanks. That's great. Mark.
This was a fascinating collection of panel and information. And I'm really curious about the community-led monitoring. To what extent is it a norm to share the results of monitoring with the respondents and the community of the respondents? Because often, at least from a U.S. perspective, I hear from people who participate in this that, you came, you asked for the information, we didn't get it, and that wasn't shared within the community. So just curious what that looks like in the work that you all have done.
So great question. I think it's an area we can improve on. Generally, the community-led monitoring results are shared back with the PEPFAR team, which is the U.S. government agencies that are responsible for implementing. There is sort of a gradual push to encourage the community-led monitoring organization to also provide the results back to the Ministry of Health and to the facilities. But even on top of that, it would be ideal if they were also giving the results back to the community that provided that data. And so I think there is a report that's published in the places where community-led monitoring is implemented, and that report is distributed. But I think we could do even better about getting the results back to the community that was surveyed.
Thank you. I just want to add to that because I was aware of one study in a Caribbean nation where that safety data was actually used to identify the places where you could seek care where you wouldn't be menaced. And so it was really actually, we show them where to go instead of relying on trying to convert some of those places that might need a long way to go in that conversion. Thank you.
Great, thanks. Next up was Leo.
Thank you. And thank you to all the panelists. My question is for Katie. Katie, I wanted to hear more about that trans advocacy group that you mentioned at Crescent Care. What's the composition of it? And then I was also interested in hearing if there were any challenges in implementing any of the recommendations that might have been brought forth by the group. Thanks.
Thanks. Yes. So the Trans Advisory Council, I think that it sort of followed on the heels of, we had previously a Black Advisory Council. It was a Black Leadership Advisory Council that was started by some employees also who felt that, we really needed to focus on having more anti-racist care and also focus more on our Black patients because, historically our organization was more of a white gay male organization when it started. And so that group really helped to center conversations and reshift focus for who our community is now that is impacted the most by HIV and what we should be doing as an organization. So the Trans Advisory Council followed some staff members after that. It was definitely primarily led by trans and gender nonconforming staff members. And since then, it no longer exists at our clinic because it has expanded and grown and joined with other groups in the city. And now it is a citywide group called Tidal, and they are amazing. And they are made up of multiple healthcare providers who are trans or non-binary, as well as community members. And they offer lots of trainings and presentations and things to healthcare clinics throughout the city and throughout the state. And so that's a thing that has really grown and expanded. So I know that they do a lot of advocacy over the laws that are always trying to be passed in Louisiana and elsewhere. But they also set up some really amazing trainings where they will go into some of the larger healthcare systems and hospitals and provide these trainings for the staff. And they also will sometimes do, they can be hired to do evaluations for those places as well, and look at maybe some things that, need to be improved in how they're providing services. They're also a good place for community members to report experiences to, and then they can sort of advocate and follow up with those clinics to see what's going on. So it's expanded. There was a Trans Advisory Council at Crescent Care, and now it's no longer housed there, and it's now a much larger organization throughout the city.
Great, thanks. Next up is John. Oh, okay. And I have Ada.
So thank you again. Great conversation. I had a couple things that I was taking note of. And one thing that I wanted to kind of ask the question, but I guess a comment also. You know, when we think about stigma and discrimination, and someone mentioned it, I can't recall who it was, you know, really getting to the root cause, which is structural racism. And, you know, how do we typically approach that because we know that the policies and procedures, and I was going to ask Katie also, you know, how did you get buy-in, you know, from the top down, because that's difficult within a lot of, you know, community health centers and other clinics to get everyone on board to be able to be culturally sensitive and apply cultural humility. Also address implicit bias, you know, all these things that we know that can get to the root cause of all of this, which is, you know, the bottom line of addressing structural racism. So just wanted to see if there was anything that you all could really elevate to, you know, on the global side and also on the domestic side that we can do to truly address, you know, not only looking at, I would say advocacy, but, you know, what else could we really do to address structural racism, I guess is my question.
Just a big question like that, but a really important one. Anybody on the panel want to provide thoughts on that, or anybody really?
So maybe not. Well, okay. So the example that comes to mind when you think about like structural racism in health is the Black Panthers and the health programs they ran that were part of a political analysis and a political action plan to serve those goals of addressing racism. So I'm not asking for a revival of the Black Panthers. I'm saying that I think it's a political problem and it kind of requires political organizing that may not be the kind of political organizing that may be very difficult to initiate from inside this huge health bureaucracy machine. But there are things I think that you can do to support that kind of political organizing, like just listening to what they're saying and trying to not dismiss really, really radical ideas, because we have a lot of problems that require that kind of thinking to get out of. So I would say, like, everywhere with homophobia, it's similar, right? Because when I think about homophobia, it's not just like the stigma that happens in the clinical encounter. It's like the idea that vaccine that was available and sitting somewhere was sitting somewhere instead of in our bodies. So that indicates that something is going on there. And that kind of problem can't be solved from inside the bureaucracy. There needs to be activists who can hold those decision makers to account from the outside, because of course, like, if you try to do that from the inside, you will just sap your energy. So I think, for me, I think it's always like about being aware of activity, political activity that might have relevance, but not trying to make the Black Panthers inside Harvard University. That makes sense.
I have a much small, not insignificant, but a smaller scale example that's easier maybe to think about. And it's something that you, Gletso, did with your research. And I'll give a COVID example as well. But what you did essentially was assume that there is structural racism, which there is, and then you went about a process to document where people were, so that given that you could direct resources to where people were, because the system wouldn't be able to do it otherwise. And in the context of COVID vaccination, when COVID vaccines were first being rolled out, we did a lot of analysis of what states and communities were doing. If everyone remembers back then, when there was limited supply and everybody wanted to get vaccinated, and there was concerns about the most vulnerable not being put early on in the line, but also even when it was someone's turn, people would not easily get access for a whole variety of reasons. Some communities really were incredibly proactive in finding ways to do a type of approach, which is how do you think about allocation differently. Some processes didn't work, but some were really creative. And I think that's one way to approach it is you given that it's really hard to make that broad system level, state level, or country level change, or there's community interventions that kind of get around some of the structural challenge that's already built in. So next up on my list was Mike.
Could I add something to that, or are we not allowed to?
You are very much allowed and welcome to add.
I just want to say that I think that we can build alternative structures as well. We can't build the Black Panthers inside of Harvard, but the free lunch programs at schools came out of the Black Panther Party. There are many things that domestic violence shelters came out of the women's movement, who started their separate alternative options that were later absorbed by larger structures. So I wouldn't put aside the idea that communities can build their own alternatives. And I think in addition to that, moving outside of the health sector is also critical because HIV doesn't happen only inside a clinic. And I think one of the things that we're working on here in terms of structural racism is an alternative to police response. So unarmed responders, because engagement with law enforcement and with the carceral system is a huge driver of HIV and a huge reason that people living with HIV fall out of care. So being able to address the structural racism that's built into those systems and create alternative systems is also really important. And I think another strategy in addition to all the other ones that people have named.
Great. Just so people know who's up, I have Mike, John, Tori, and Vincent.
Okay, thanks. When I was listening, a lot of what I heard was what I would refer to as a lot of external stigma, that is outright discrimination, hate, that type of thing, and that certainly exists. The more subtle and maybe more difficult to address is internalized stigma, where there may not be a identifiable action, but just a personal feeling that can be a barrier to care, a barrier to access. And I may address this specifically to you because of the Mpox story. It reminded me so much of the early days of HIV with KS lesions on the face, as if saying, look at me, here I am. And that created a lot of internalized stigma, even if people maybe weren't thinking about the person in a way that they imagined. That imaginary stuff is very real. So how did you address that? And maybe we can generalize the comments in terms of specific actions that we can take to address internalized stigma to overcome barriers to access to care in particular.
Thank you for the question. I think that, internalized stigma is always kind of secondary to stigma to me. So I think of interventions on the stigma side mainly. But implicitly, what we did by talking about group sex in a way that doesn't make it seem like such a strange activity, doesn't make it seem like a really risky thing to do, that uses the language, that plays with the language that people use so they can see the language they use to communicate with each other about hooking up. I think those decisions kind of also came from a place of like, okay, I understand there's some tripwires in this situation. The best I can do, because I can't reach everyone and say, and like talk through, the very important and very real internalized attitudes that might not motivate them to seek care. Like, I don't think there's space to do that for me personally, but I can try to make sure that when I talk about their experiences and their desires, I talk about those in a way that respects them, in a way that accepts them as they are, in a way that that stops other people who are looking at the conversation from laying blame on the people who are experiencing the thing that's being experienced. So I think for me, as my own practice is to think about like what it is I know is going to set people off when I communicate about my work.
Just to add to that, I think something else we saw, especially in the MPOX response, was lots of predominantly gay and bisexual men were telling their own stories about their experience. And really that authentic storytelling was a way to combat some of that internalized stigma, where people could sort of see other people who had similar experiences being honest and transparent about what was happening to them, right? And so that, I think, is a powerful way to mitigate both stigma from the outside, but also can also serve as a way to mitigate stigma from within. And I think what kind of fosters that is to make sure that people have the right information so that folks within community can then take that, put that in their own words, and then put it back out. So I think from our standpoint as kind of public health folks, it's about making sure that we're disseminating that information to kind of the right folks so that they can then take it upon themselves and build authentic stories around that. So I think that's another way that community power really showed up in this particular response. And I think that did a lot to mitigate some of that internal stigma. And I think in many ways, that can be applied to, HIV. So, again, another example from Atlanta and Thrive SS, they created their own social marketing campaign that featured the lived experiences of their own members, right? And to really show what it looks like to live healthily with HIV. And so I think those things can have powerful impacts on stigma. So both internalized and external. Just wanted to add that.
Great. Thanks, John Weisman. This conversation is incredibly, I think, powerful in the sort of layers of this, the many layers of this conversation. Just keep peeling this back, whether it's from the individual sort of internalized homophobias, et cetera, or the, how that translates to care and clinics and access. But I want to just ask a little bit different approach to something here. And this might be those of you who have experience in the PEPFAR world might be sort of most applicable, but obviously everyone weigh in. So what I'm thinking about is the increasingly harmful environment we have in the United States with the laws that are being passed right now, which basically prevent people from getting gender affirming care. Laws that are preventing people from bringing their lived experience into the room. And I mean, this to me feels again like a very another high level danger level that we're in. And if we're going to address laws about decriminalizing, HIV, and we're going to ask to make progress in states on some of the things we talked about earlier in terms of molecular HIV surveillance and cluster detection response, the environment in which we are going is very risky and hostile. I mean, it is outright hostile and hatred for individuals. And you can't put any bow on that. That's what it is. And so in this environment we are, this is obviously politics, and this is about people who make our public policy. So my connection about thinking global and local, like those of you who have worked in the PEPFAR land and, with governments and individuals and governments who make policy, do you have any sort of best practices or approaches you've used at that level? I get we need to politically organize, right? And we had and made some incredible gains over the years, and now those are really under attack. So if I try to think about this level of work that we need to do in addition to all of the levels of work we're talking about, do you have any thoughts on this that can translate from those of you who have had the global experience trying to work with governments and countries on what I feel like is now I mean, we are like rapidly going to have a difficult time talking to other countries about what they need to do given our own situation here. Another easy question to solve.
I think what you're describing is the situation for most of us, which means that there are lots of experiences to draw from. For example, there's an old joke about like the Department of Health is in charge of handing out condoms, and then the police or the Department of whatever is in charge of arresting you for them or taking them away, or something like that. People have built like little corners of protection in very, very difficult environments. In Uganda, in Zimbabwe, under Mugabe, like there are things that people have done. There are experiences that they've been through and are still alive after having experienced that I think at this time are so crucial. So I think rather than saying the US now has a hard time telling people what to do, I think it's a recognition that the US never had. The US was never ready to tell anyone about anything. So, but it is like, so there are resources that the US has that most places don't have. And I think maybe it's time to think about how to use those resources to set up meetings, committees, whatever, like set up activities that can create that exchange between leaders of civil society who have survived, like really difficult administrations. Because there's always something that can be done. The health people are always not as bad as the police, for example. So you could start by saying, okay, let's figure out like how do we buffer some of this policy from inside like big health bureaucracies? Are there opportunities there to like ignore, or I don't know, now I'm circulating, I don't know a lot about these systems. I'm just saying that inside the system, are there resources that can be mobilized to help? For example, HIV has actually funded the start of LGBT movements across Africa in different ways, from like, oh, we have a safe space, we have like a discussion group, you can come, and then the people eventually will say, why don't we just like set up an organization and do the things that we've been talking about in this discussion group for so long? So there are opportunities for similar work to happen here. It won't happen the same way. Of course, the history is different, but I just think that this situation is not exceptional in the context of LGBT rights globally.
William or Tonya, do you want to say anything from your PEPFAR experience on this? You don't have to.
I'll agree with Kalitza that it's not so much a matter of the U.S. Telling countries how they should change their laws. It should come from within, and if PEPFAR or the U.S. government can create that space for LGBT organizations to organize, to bring parliamentarians together, then there can be slow progress. But it's always in some countries it's steps backward and then steps forward. Uganda, Zambia, Kenya, there have been recent either the laws or rhetoric that has just been hostile towards LGBT people. So it's a tricky balance of how to use the power of PEPFAR, the power of the purse, the diplomatic powers that it has, and not create the defensiveness, not create a backlash, not create sort of entrenchment from the government, from the ministries that are more harsher or more on the criminalization side. So I'd say foster the growth from within rather than have it be a U.S. influence or recommendation.
I'll try to be brief. I think if your question was about what lessons can be learned from work in the global environment for this particular moment in the U.S., I think that we can draw on historical moments in the U.S. For a little bit of hope. Whenever I feel very despondent about the state of politics, I remember that there was a time in this country not that long ago where I would have been owned by another person, and that was national. And if that could change, then change is possible. And it will take strategic organizing. It will take creating alternatives like an underground railroad for gender affirming care. And it will take strategies to access political power to be able to make change at the local, state, and national level. Now, that's obviously not as simple as the way I just said it, but I do think that those are strategies we can learn from our own past and lessons that we can learn from other places.
Thank you. I have Tori, Vincent, and Harold. Tori.
Thank you. I just want to say thank you to all of the panelists. This has been really wonderful. And mine isn't so much as a question, but more of a comment. I also wanted to thank you, Dr. Makafani. Yes. I saw someone's name up there and I texted her. I was really, really excited because those are folks who are part of the community who are being engaged as co-investigators. I think that's wonderful. And then I would be remiss if I didn't really just take a moment and thank you, Dr. Poteet, in particular, for many, many years of academic advocacy. You have created resources that were not available until you created them. And you have really, in many, many ways, I think, changed hearts and minds simply by being brilliant and compassionate and dedicated. And so, again, I would be remiss if I didn't take a moment to say that in front of all these really well-connected folks.
You're here to that. Vincent.
So I'm not sure where to go after all of those comments. I too am a fan of Dr. Poteet, but I'm going to try to come back to a couple of observations. One, the panel was fantastic, and today's meeting as a whole, I've really been impressed by how much we've been talking about what I'll call very sensitive and delicate issues. And the one that resonated the most with me was actually Dr. Stewart's, Ada's question about racism. And so I want us to maybe take a moment to at least think about that again. The question was, what can we do? And I think if this is fair, that collectively there was recognition that that's a really big question. And yet it occurs to me that that at least during the time that I've been part of PACHA, that we haven't really spoken about racism and its impact on HIV and health more broadly. And I want to challenge us a little bit as a group to recognize that oftentimes we use sort of static models or domain-specific constructs. We use other words that in my mind are proxy words. We might use things like something that I heard today, and again, this is in no way a criticism, vulnerability. And, as I've read literature on sort of racism and health inequities, I've seen really smart people who I've learned a lot from, like Dr. Thomas Levi's, kind of question vulnerability and say, is it really an opaque construct that really masks sort of exposure and susceptibility? And is it possible that we actually do know more? And that if we spend some time moving away from more static models and sort of thinking about interventions and what we can do about it as a country, that we might advance HIV and other health inequities. So I guess what I'm trying to say in a very long-winded kind of set of words is I hope that as a group that PACHA will, at some point, Marlene and John, think about focusing one of our meetings on the role of racism in HIV.
Thank you. It's actually probably perfect time for Harold to speak, given what the national strategy addresses this directly.
Thank you very much. And thank you to the panel. This was excellent. And thanks to our PEPFAR colleagues, because as was stated earlier, we do continue to try to look for opportunities for bidirectional lessons learned. The 5-year strategy that was released by PEPFAR and Secretary Blinken in the fall of last year also includes reference to our national HIV/AIDS strategy and our work to end the HIV epidemic. And so for the first time, I think we are much more in alignment in our goals in trying to advance our HIV mission. I think it's often hard to follow Vincent, but I think he raises a really great point. We talk about racism as a public health threat within our national HIV/AIDS strategy, and as such, recognize that some of that these structures and systems that have gotten us to this point don't work the same way for everyone, and that there are differences that we need to explore, and that we do need to think about what this means for our overall HIV response. John asked a question that I have wrestled with a lot, also being, I'm not quite a PEPFAR alum yet, since I'm still involved and engaged. But one of the things that I think makes PEPFAR unique and its ability to move things forward in countries where the social or cultural construct is such that it excludes certain individuals, especially key populations, is that usually when the U.S. is approaching a country and working in terms of trying to advance the goals of PEPFAR, there is an overall U.S. mission that includes certain goals, strategies, and priorities for each country. And I think one of the things that makes us different in our United States response is that we've tried to look at all states as the United States and treated them as one group, when we are seeing more and more that there are differences in the approach and the acceptance of both now federal funding for HIV and also our other overall goals. And so within sort of that international context, there's also diplomatic levers that can be pulled or pushed that help sort of open the doors for PEPFAR and open the doors for support for civil society. I think the other thing to sort of think about is that those diplomatic levers include not only resources from PEPFAR in terms of health and overall well-being, but also some of those trade agreements that we also have with agencies. And I've been in those rooms where we've had to say to certain countries, you know, if you don't accept sort of what we're bringing to the table in terms of PEPFAR and the work that needs to be done that is more inclusive and includes civil society, then certain trade agreements are going to be held up or delayed or not approved at all. And so it becomes a package of U.S. support as we move. Now, I'm not advocating that we go down that road, especially given where I sit these days, but I think we do need to think about comprehensively, how do we approach not only HIV within that space, but also some of our other public health goals for some of the states and some of the communities. The other thing I think that was said that is really important is the support in PEPFAR countries for civil society. Because I think that we are at a time in our country where, and I can say this, we have an administration that understands and gets it, and values equity and inclusion. I think there's not a week that goes by where President Biden doesn't talk about equity, inclusion, and making sure that that marginalized groups feel included and heard, and that they know they have a space at the table. I think within HHS we have that. But what I have been saying to a lot of our civil society groups is a lot of this has to happen at the state and local level. And I think we have to find a way from the federal level to support groups at the state and local level to be able to have that dialogue within those contexts, much like we support civil society in PEPFAR supported countries, to have that dialogue with their own host country governments. That's what I got.
So I think this has been such a rich conversation. And I want to have us sort of, again, try to draw up some kind of general learnings. And so I'm just curious for each of you in the spaces in which you work, as we think about ways to address stigma, are there things that you would invite us to do more of? Are there things that you would invite us to do less of? And I think just thinking a little bit about, if you can get to it, how should we think about, of the things that you want to do more of, how do we think about keeping those efforts going, and how do we think towards sustainability for things that are working well? Anybody want to take that?
Well, I can answer narrowly, kind of from my perspective. I think it would be useful for there to be clear structures that are government and civil society that are not dominated by government, firstly. And then secondly, there's some kind of like really routine tasks that it's always surprising they don't get it absolutely right the first time, like publishing health communications about what's happening and making sure that it looks beautiful. Because like the first offense is putting something ugly out and expecting people to engage with it. So it has to look beautiful. There are people there who will tell you what kind of emoji to use or not to use, or what's missing. There are people who will tell you like what language people are using right now to describe what's happening. And for that to not be kind of routine, for there not to be a place where you can just go and say, this is what we need to do. We need a turnaround by next week, Wednesday, I think is shocking for like the kind of, for how easy it is. So I think they're just like a few things, especially at the local level, where it's useful. It would be useful to set up a structure that people commit to, that civil society can commit to, where people hash out responses and really deeply consult, not just kind of like speak to 2-3 people, ask if this image is fine, and then publish.
Anyone else?
Mine might be too specific, but I think that we always need more support for housing, just nationwide, in terms of HIV programs. It's definitely one of our big problems in New Orleans. I know rent prices everywhere have gone up, so that's like always a thing that we have a big problem with. And then also I think that Rapid Start, I know is been accepted as, you know, golden standard of care. It's part of EHE, Fast Track Cities, you know, these initiatives. But I think really trying to enforce and hold places accountable for not doing Rapid Start is really important, because it is a way to guarantee that people are getting life-saving treatment quickly, and also that they're not being biased, you know, from the provider side or the clinic side. It's a very straightforward clinical intervention that can really help eliminate that. And we started doing it in New Orleans. I was the linkage navigator for it in December 2016. So we were able to do it here. I really think that everyone needs to catch up and start implementing it. And I think that there could be some more encouragement or pressure in terms of, you know, funding and things like that. I think it really needs to be a priority for making HIV care equitable and linking people to care right away. Thanks.
I can speak on the domestic side in terms of healthcare. We have lots of models for holding healthcare providers accountable and health systems accountable. So the like JCO visits that everybody freaks out about when they're coming to clinic. You have to have make sure nothing's outdated and everything's fine. And healthcare providers have to get in a certain amount of CME. So if we embed anti-stigma interventions that are effective within those mechanisms that hold people accountable and that are recurring. You know, you have to get a certain number of CME hours every year or 2 years. JCO has to come and inspect a facility ever so often. What if one of the criteria for accountability was that site collected SOGI data, or that people provided gender-affirming care, or that LGBTQ clients at a site had to give a certain level of ranking to how well they were treated at the facility. These are just like off the top of my head, but I'm thinking about structures that already exist that we can embed these anti-stigma or destigmatizing interventions within to make them, honestly, they need to outlive any administration. They need to outlive special initiatives. And those are a few ways I can think about being able to do that, at least at the clinical level.
Thank you. All right. Well, I think what I'll ask is if the panelists have any very quick concluding comments that they'd like to offer as we round out this really fabulous panel. So maybe we'll start in reverse, and just Tonya, if you have any closing thoughts, then we'll go to William, then to Calypso, and then to Katie.
I have closing gratitude. Just thank you for all of you who are on PACHA and the great work that you do, and for all of you who spoke so passionately on the panel and in the room about this issue. I am also a clinician 1 day a week. I'm a clinician all the time, but I'm in clinic 1 day a week. And the biggest barrier that I see to people being able to engage effectively in care is usually structural, like finance, distance, transportation, housing, all those things that Katie talked about. And the second is stigma and discrimination. So thank you for prioritizing this and giving this a big space on your agenda.
Likewise, I'd like to thank the panel for creating the opportunity for bidirectional learning. I think it's such a wonderful space where PEPFAR can learn from what's happening in the U.S. and vice versa. So it's great to visit or be part of this panel today, and hope to continue the shared learning. And I agree with what Tonya just said, that most of the barriers are those structural barriers of distance, of cost, of education, of stigma and discrimination, and that if we can tackle those, then the health outcomes will follow. So thank you.
Yeah, thank you for inviting me, and thank you for this discussion. I've had fun, so I'm glad I came. I think my hope is that just the idea that ideas can come from outside the US that are useful my hope is that will just increase a little bit. The idea that you can speak to a Ugandan, you can speak to a Zimbabwean and ask them, this is what we're experiencing in Tennessee. Like, what have you seen this? And like, what have you done? Because the leaders of LGBT organizations in these countries are amazing leaders, amazing thinkers, and a lot of the work they do is intellectual work. So my hope is that we will take advantage of some of that intellectual work in dealing with what is happening here.
I don't really want to follow that point because it's so good and so crucial. Because I really think that there's so much that we need to be following suit from these other countries that are doing amazing work with a lot less resources than we have, and we should really be following their lead. I would say that as a closing remark, first, thanks for having me. This has been really great, and I'm happy to be a part of it. And I would say that I do think that Medicaid expansion was really important for Louisiana, and that any movement in that direction that we can do to increase access and healthcare coverage for people will really make a big difference and help even the playing field for people to access care. And I think that increasing access is really the #1 way to get rid of some of the inequities that we have in the healthcare system. So I just wanted to throw that out there. Thanks so much for having me, you guys.
Please join me in giving our panelists a round of applause. Back to you, Madam Chair or Mr. Chair.
Yeah, thank you so much. This is an amazing conversation to lift up. And for those of you who have been following PACHA, we take these conversations, build upon them, figure out where we go on agendas, where we need to go with recommendations to the federal government in terms of our role. So this is a conversation that we've certainly had off and on. We have a stigma and what's the second part of your
disparities?
It is disparities. Okay. All of a sudden, I wasn't sure it was disparities. Subcommittee that works on this as well as our global health. So thanks for coming together on that. As soon as I finish talking, we're going to take 5 minutes and just 5-minute break. We're going to start public comment a couple minutes late, but in advance of that, public comment will be coming up. Those of you who are speaking, you'll have 3 minutes for public comments. There will be a timer. You'll also be let know when you have 1 minute left. So that's coming up next. I wanted to acknowledge that PACHA Council member Vincent Guillermo Ramos is on the call, joined us since I think the roll call, and Wendy Armstrong, our liaison from the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment, is on the call as well. And I don't know if we had any other PACHA members join, but those are the ones that we noticed. Also, PACHA members and any federal members who are going to be here tomorrow, if you wanted to order lunch in advance from Potbelly but didn't, if you can see Stephanie, you can still get that order in for lunch tomorrow. And I think those are the announcements. So we will literally take 5 minutes and be back for public comment and then our PACHA-to-the-People. Thank you.
Produced by the U.S. Department of Health and Human Services.